औज़ुबिल्लाहिमिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम अर्रहमान अल्लमल कुरान खलक़ल इंसान अल्लमहुल बयान. Use time now because the future depends on what you do today. जैसा कि आप लोग जानते हैं कि आप लोगों की रहनुमाई के लिए मैंने हिस्ट्रीज़ के बाद अभी शॉर्ट केसेस का सिलसिला शुरू किया हुआ है. आज के सिलसिले का शॉर्ट केस है एक्यूट फ्लैसिड पैरालिसिस. तो इसमें एग्जामिनर आपको कमांड दे सकते हैं कि दिस चाइल्ड हैज़ अ वीकनेस ऑफ लोअर लिम्स, एग्जामिन द मोटर सिस्टम ऑफ लोअर लिम्स एंड रेलिवेंट. और वही स्टार्ट आपने करना है. इंट्रोडक्शन, कंसेंट, एक्सपोजर, रेपो, हैंड सैनिटाइजेशन. The exposure should be ideally just underwear or pants above the knee joints. Then after that, go for a general look, see whether the child is sick looking or well looking. Is cyanosis or respiratory distress at rest, is pallor or jaundice, the nutrition status, diagnostic or dysmorphic features. Before proceeding further, ask the child if he or she is able to walk, and if the child is able to walk, then perform a full gait examination, including squatting and Romberg's test and Gowers sign. If the child is unable to walk, then start with the motor system. First, the lower limbs, check the fasciculations, bulk, which is lost in lower motor neuron lesions, tone, power, reflexes, clonus and coordination, superficial abdominal reflexes, followed by the upper limb examination. Then you have to sensory system to ascertain the sensory level because in transverse myelitis there is a sharp sensory level. Then go for the face. Check the cranial nerves 3, 4 and 6, eye movements, H type and the fifth nerve. Seventh facial movement, forehead, eye and ask the child to fill air in the mouth. The ninth and tenth are checked together, gag reflex, say ah, then 12 is tongue out. So this is to see whether there is where is the lesion. Then abdomen is examined and the bladder is palpated to see the palpable bladder. Then you see the back. There can be the malegomyelocele or spinal cord surgery, scar marks or a mass. Then look for the bed sores. Ask for doing digital rectal examination for patulous anus. At the end of the examination, ask for checking blood pressure. Blood pressure will be decreased in GBS. Take height and weight and ask to plot them on centile charts. I have made a hypothetical description. I've just examined 6-year-old boy Junaid, who is sick or well-looking child, under or adequately nourished, with no respiratory distress and cyanosis at rest. He was conscious and cooperative during my examination, with a nasogastric tube and cannula in place in the right hand. The child is having normal bulk and tone is reduced bilaterally in all four limbs. Power was 2 by 5 in the lower limbs and 3 by 5 in upper limbs. The reflexes were absent and plantars are downgoing. I was not able to assess gait because the child was unable to walk. Gag and air reflexes were absent. All other cranial accessible nerves are intact and spine is normal. Bladder is not palpable and there is no sensory deficit. I would like to take blood pressure, height and weight and plot them on centile charts. So the examiner will then ask about the differentials. The top differential will be Guillain-Barré syndrome, and in the investigations will be NCS or electromyography nerve conduction studies, CSF in which there will be elevated CSF protein greater than 45 mg per deciliter, anti-ganglioside antibodies. Treatment is mainly supportive such as care of blood pressure, bowel and bladder. Indications of ICU admissions are flaccid quadriparesis, rapidly progressive weakness, reduced vital capacity, bulbar palsy. Then IVIG is given, plasmapheresis is done, and steroids and physiotherapy. There is a transverse myelitis. The MRI findings are fusiform swelling or high intensity T2 weighted images and distension of the spinal cord in affected segments, gadolinium enhancement. Treatment is methylprednisolone pulses in a patient which who have no motor impairment, while plasma exchange along with glucocorticoids is given in patients with motor impairment. Then bladder and bowel care. Polio, in which the two stool cultures are sent 24 to 48 hours apart. The treatment is supportive and such as physiotherapy, neutral position, there should not be any intramuscular injection, and passive range of movement exercises, NG feeding, and respiratory support. Thank you all for listening. This is just basic guidance or guideline for you to examine the child who has an acute flaccid paralysis. You can improve upon it and you can make your own diagnoses and examination techniques. I pray that may Allah be our helper, our protector, and our guide. You can join my Facebook, WhatsApp group, which I'm trying to make a group for guidance, which you can guide each other. And I will be looking forward for your feedback. Allah Hafiz.